Testing, 1, 2. Check, check, 1. Check, check. Colleen? So that last one you sent over, the presentation, that's the final one, the latest draft? Okay.
I could too. She did the one sitting over. There was another one that was even funnier because it was like a somewhat more serious celebrity, but I can't remember who it was. Yes, that's the one for real.
All right.
And
I just need to swap
I'll just
those.
show you. And did you switch the lip sync one into?
Not
Not
yet,
yet,
but
okay.
I will do that.
You could just, yeah, that's fine.
It's that one.
Right. And I'll show you the you just once it's in presentation mode, if you just click on that, it plays the song. Or it should. No, it's not going to. Okay. Well, it did at my office, but
Yeah, that's
it's fine. It doesn't matter because you guys can pull it up, right?
yeah.
Okay.
I think it's just a format that it's saved in.
Okay.
All right, so I just need to swap these two, right, from lip sync 1 to lip sync 2.
If you want, if it would be easier, you could do Denise. You can type that one. Denise.
So this will be technically the second one.
Yes.
Okay.
And maybe put a 2. And then the other one is Chuck Carr. And I know who these people are, right?
Oh, wait a minute.
Chuck Carr.
Chakar?
Uh-huh.
Like,
Chuck. Sorry.
oh, Chuck. Oh.
Not Chuck.
Oh. Chuck R.
R. H-A-R-R.
Oh.
Sorry. H-A-R-R. 1. Okay.
Gotcha.
Can we just listen to it and make sure that it's right? Okay. Yep. Okay. You can turn it off. That's good. All right. We're good. Thank you.
Right. Log out here. What you need me to do? Uh-huh. Mhm. Oh, okay. So it's at 52 right now. I'll put it up to 85. Yeah, yeah, I did.
You mean the row along the wall?
Oh, okay. Hmm.
I think if we just tilt the chairs and go over there, that means. Do you want me to go ahead and get the pins so they're? No. You can throw something down. Well, so there's a person beside you.
Okay.
He has them? Okay.
I'll be over there in the corner. I can come run quickly over here, whacking them.
Oh, yeah. Oh, okay, okay.
The number of times these
Gotcha.
swords come at you, you can kind of tell.
Yeah. 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 I didn't think about that really. But
livelier to walk around, but I'm gonna start off with it, even if that's a placeholder. Do I just take this one? I'll just use this one.
You can turn it on off and choose.
All right. I do. I want to stick it.
Yep, see right there. Right there.
Okay, it's not on.
You guys have to talk about it. That's like a light thing.
So I'll keep it off when I start. When you start asking questions. Pressure on the song. No, I understand they have the guys going first. Is that right? Is that
Yeah. I think last time.
Rico Iglesias or somewhere?
Chuck's, yeah.
Yeah.
What's the intros? I think so. Yes, ma'am.
In the front.
Okay.
You got chairs.
All right. Hello, everybody, and welcome. Woohoo! We are your zero chasers. So we told you wouldn't want to miss out. And I highly encourage you to stay to the end because it only gets better after the panel discussion. And you absolutely would not want to miss that. So with that, thank you for coming. I'm going to turn it directly over to Dr. Paul and Cindy, who have done a phenomenal job getting this together. Our thanks to PR and Colleen, who have been incredibly creative to get us going. So you guys ready?
Yes, we are. Good. Take it away. So for those of you who don't know, Cindy and I are dyad partners in quality. We're working hard on this, and this is something, and I'm going to surprise you, this is something that we haven't been doing for a long time. Let's talk about chasing zero, because that's what this is about. Thank you. So, the Chase Zero is on, and you saw this up before, and I'm going to get to my presentation. What is it? What is Chasing Zero? So, a couple of things. This is our internal messaging around getting the best care to our patients every single time, every single day, with every single person here. Doctors, nurses, tech staff, everyone. Everyone is going to chase zero. Will we catch zero? And we're going to talk about what zero is in a moment. I don't know. But if we chase it, we're going to get darn close. I'm going to tell you, some of us already have caught zero, and we'll talk about how we'll do this. This is a comprehensive framework. A lot of words on the slide. This is our North Star. Everything we do, infections, zero. Zero defects around washing hands. Zero harm, zero falls. Is it attainable? Yes, it is attainable. There are organizations within this country that have attained these, and this is what we're going to go after. And if we don't meet it, I don't really care. We're chasing it. We're going to continue to chase it over and over and over again. Now, I'm wearing my WakeMed Excellence hat because this is not anything new. I don't want to reiterate. This is not new. This is giving us, management, executives, our employees, our North Star to go after. But it is nothing new. WakeMed Excellence, process improvement, we're always about zero defects. Those of you who have been through the training know it's about zero defects. It seems impossible. But I will tell you, one of our campuses had zero collapses for 14 months. Incredible. You'll hear more about that later. So it is incredible. There are units in our hospital at WakeMed Raleigh, WakeMed Cary that have had zero collapses, zero qualities, zero falls. It can be done. We have to learn from each other, and we have to simply do it. So a little bit around what is preventable harm, because we talk about preventable harm. It's any harm to our patients, any harm that we may have had an opportunity that we didn't seize. We didn't follow policy, we didn't follow procedure, we didn't follow best practice. It was any time harm beset our patients and we really didn't follow it. But some examples, and you'll know them, that you see, hospital-acquired infections. We have ways to prevent them. Sometimes we don't always follow them. Falls with injury, sepsis deaths without following our bundle, and we've done incredible on doing this. We are best in the country right now at following the sepsis bundle. Collaborative efforts with nurses, doctors, IT, everyone has been in this, and we've got some of the best sepsis bundle rates in the country, and our mortality has dropped. Those are real lives. Those are people that walk out because of that. Wrong site surgery, God forbid it ever happens. It hasn't happened here in a long time. We've hit that. But other things, wrong procedures, retained foreign bodies, medication errors. Yes, they're a fact of life. How do we chase zero? This is all about chasing zero. And this is something everyone can understand. Everyone can understand this is where we're heading. Pressure ulcers acquired in the hospital, blood clots after surgery where we didn't do our job at getting the squeezers on the legs, getting the heparin in, prevention, and more. And there's a lot of these we're going to look at over time. So a lot of this is logistics. How can we help our staff? Zero is simple to understand. Zero is simple. It's not we're getting this rate or this level. We're attacking zero. Understand that. Following policies, procedures all the times, including, and there's a list here, but we're going to hold each other accountable to doing this, to really going after this with a vengeance. Following best practice according to evidence-based practices, including all of these. Getting catheters out, following falls preventions, sepsis bundles, I've mentioned this. All of this goes to chasing zero, but it can be as simple as washing your hands. Now I say that because there's an organization in Scotland, the Scottish Health System, that just attacked zero defects of washing hands. They dropped their CLABSI rate to zero for 4 years. Just by washing hands, zero defects. So it is not something complex. Everyone can do this. Everyone can participate, and we've got to make sure we hold everyone accountable. So, campaign timeline, Chasing Zero pre-launch, you're seeing today. Chasing Zero launch August 6th. You're going to see major efforts from PR, packets going out. There's going to be a managerial toolkit that you can come out. I will come to any unit and preach on this. Yeah, it's kind of preaching. Sorry, it is kind of preaching. I will talk on this. Our first focus for the quarter, this isn't a one and done. This is going to continue. First quarter hand hygiene focus. We know we do well, but do we really do well? We survey ourselves. We get close to 98, 99%. We had some units, Sheldrick will talk a little bit about this, that weren't doing as well, 70 and 80%, have done things getting that back up to 100%. That's what's acceptable, no defects. Really, no defects as we go. Q2 was hospital-acquired infections directly related to the other. The next one may be falls. Every quarter we are going to concentrate. We don't forget the previous ones, but we're going to concentrate on those going forward. So, the pre-launch campaign, July and August, SLT and OLT, you can see I convinced them to wear these silly costumes. Please stay to the end because the entertainment is really then, I'm just saying. July 25th, management staff meeting, that's you guys. The MECs are in progress now. They'll get some of this tonight. I don't know if I'll wear my cape or my mask or not. And others, SQUAP, QAPI, these are our quality performance. We've already done this. JCQC has already gotten this, and the board is well aware of this. I am hoping that the other end of the camera is our Joint Commission surveyors in Cary. They were very interested in this, and I will say their presentation at the beginning of this was talking about zero harm. I said, yeah, we got you beat. We're already doing it. We are. We're ahead of the curve.
Thank you, Dr. Paul, my superhero. So I want you to just reflect as individual leaders in this organization just for a moment and ask yourself, now why the heck are we starting here? Because each of you is a superhero. You influence every single day the people that you come in touch with, your teams, the patients and families that you interact with, the colleagues that you help to influence and direct and help educate. So you need to feel very powerful because you are superheroes with lots of power. And with that, I'm going to turn this over to...
One more.
Oh, one more, sorry.
One more.
All right, superhero.
So I'm going to flip through this, but I want to show this slide.
Right.
So why do we really do this? Anybody know what this is other than Betsy, the risk manager? This is the number of patients that we had opportunities that we didn't take that were harmed over the past year. This is important. This is really important. And what you're seeing coming up is their names. Opportunity. I'm in front of the last name. I've got a family member having surgery here next week. Could be me, could be you, could be your family. You can say this is small, and it is. We are very good. We take care of thousands of patients every single day. But if your name is on the list, it doesn't matter. This is why we do it. And not to be on a down note, but understand, we're in case. This is fun. This is serious. So, with that, I'm going to let we'll introduce our moderator, and we're going to talk about some success stories.
Please help me join Harriet Stevenson to continue with the panel discussion. Thank you, Harriet.
Well, that's a hard act to follow, but I want a cape. I'd like a cape. I'm starting to try to think about my superhero name, too. So I know y'all are sitting out there thinking of what name you'd like to be called. That's part of the goal. Got to come up with a name, people. So I want to say thank you for being here to each person today. Look, I heard an extra laugh. Somebody had a good name out there. They just don't want to share it. So I am your moderator for the afternoon, and I get the privilege of working with these fabulous 5 panelists here as we're going to help moderate their success stories in their journey of chasing zero. And we're also going to interact today, so think of questions along this discussion where we can get you involved with helping identify some more questions along the way as you hear their great stories. So what you're going to be hearing are about 5 case studies. These are initiatives that are already underway, and they're their successes of their chasing zero journey. These 5 leaders, but also their incredible team. It's not a one-person thing. The incredible teams have worked with them and done amazing work, and we hope that what you hear from them today will help you and your team in your journey. So our goal today is for you to have an understanding of what the Chasing Zero journey is all about. We want you to get ideas. We want you to share amongst yourselves, but also celebrate the successes that we have already had. But then take back some key points that you hear from each other, and especially from our 5 panelists today, that will help you and your team continue your journey and chase after that zero, so we're all there together. So I know we're already working on this as it was just first identified. We're already in the process and we're chasing zero. It's nothing new, but we hope today you'll get some tips. And you're going to hear how some of our panelists have overcome challenges. They've stepped out of the box. They've looked at data differently, maybe data that they've gotten for years. They took a different spin on it. They looked at audits differently, and how by doing that, they've made some successes in getting to their journey of chasing zero. But I've had the chance of kind of hearing from our panelists already what some of their successes have been. And what really stood out to me is of all 5 of these case studies, there's some key things I want you to take note of. There's innovation, there's accountability, there's transparency, there's staff and physician collaboration, teamwork. And one thing that's really interesting is there's a lot about non-punitive education and coaching, which you know is a passion to me, but it's about setting a discussion that might be a difficult conversation with a positive note of how successful it can be for the patient to help support the journey of chasing zero. And the outcomes of those discussions, when put in that perspective, have helped achieve success in a few of these areas we'll hear today. So now I'm going to turn it over to our panel. And our first panelist is Mary Lynn, and I'm going to let her introduce herself to you all and tell us what zero she is chasing. Mary Lynn?
Hi, I'm Mary Lynn Bullard. I'm one of the managers in
Mary Lynn, will you hold it a little? We can't hear.
Is it on?
Just speak right up into it so they can hear.
Hi, I'm Mary Lynn Bullard. I'm one of the managers in the pathology department. And I've been with WakeMed for 28 years, and I currently oversee the north and the ambulatory sites. And the zero I'm chasing is unsuitable pathology specimen collection. And this is very important to us because we always want to be able to have the suitable specimen and the specimen correctly labeled on the patient. Fortunately or unfortunately, we see a lot of patient specimens. Closer? Okay. Wow, right on top of it. Okay. So currently,
There you go.
now I
Yay.
hear. Okay. Do I need to start over? Okay. So I'm Mary Lynn Bullard. I'm one of the managers in the pathology department. I've been with WakeMed for 28 years, and I've been in many leadership roles for pathology, but currently I'm over north in the ambulatory sites. And the zero that I'm chasing is the unsuitable specimen collection, because we always want to be able to have the suitable specimen that we're testing and it to be correctly identified with its labeling. Unfortunately, for the pathology department, we receive over 1,000 per month that we have to reject due to being unsuitable. And we have criteria that it has to meet. And this is a huge cost to the system. And it also, there's many reasons that we want to chase it to zero as much as possible, because it can delay discharge of a patient, it can delay the clinical decision making, it can cause a patient to be admitted when they shouldn't have been. There's many reasons why we always need to ensure we have the right specimen as much as possible. So some of the solutions that we put in place at North, we started with North, looking at what we were seeing and what could we do differently. So a decision with upper leadership made was we would always complete an incident report every time we received an unsuitable specimen. And what this has allowed is nursing or anyone that's doing specimen collections, the leadership to be able to follow up with that employee closer to the real time of when the incident occurred. That way they can sit down and talk with them. This happened. Do you remember anything about collecting this specimen? Some of the other things that we put in place is we created a report that went daily to the leadership to tell them exactly who the collector was and what the unsuitable, what criteria or category it fitted in. Because it was really important for them to be able to trace back who is the employee that we need to work with. Is it a one-time, or are we going to start seeing a trend with the employee? So they started doing this real-time feedback with the employee and education and retraining, and we started to see the improvements. And in 2016, we were seeing, we had like a 98% suitable specimen rate. And we had 1 month out of the year that they achieved 99% suitable. The following year, they went to 6 months having 99% suitable rates. And I am excluding the ED currently from this data. With the ED, it does drop some, but they do have to work with a lot of float pool staff, and they have a lot of turnover, so it is more difficult for them to keep that high standard of suitable specimens to be collected. So what we have done too is also put in place on a monthly basis to be able to really track the employees that they need to be working with. Every collector is pulled on a report, and it tells them how many specimens they collected, how many were unsuitable, and what their actual percentage rate is. This has allowed them to be able to give that re-education timely, and we've also worked with the employees to identify the ones that really didn't understand how the unsuitable specimen impacted the test results. And once they could see for themselves what the difference made, it has helped them tremendously understand the importance of their technique.
That's great. Marilyn, thank you. You are truly a suitable specimen for sharing such great information with all of us. All right, so now we're going to turn it over to Dr. Calloran. If you will introduce yourself and share what zero you are chasing.
I'm Carmen Calloran. I'm a urologist with WPP Urology, and the zero I'm chasing is CAUTIs, which is catheter-associated urinary tract infections. I have full disclosure here. I don't have a success story because our protocol and our plan is not in place yet. So hopefully next year, if we do this again, I'll be able to give you my success story. But I want to tell you what our game plan is to create success. So the reason I got involved in this is I'm not an infectious disease specialist. I'm not on any committees. I wasn't even on the CAUTI team. But as a urologist, I feel like the world views catheters as evil. And a lot of people see them as bad. They hate them. And I love them. And I'm offended that people hate them. And I love them because I see them save people's lives. And the world needs catheters, right? I mean, in the 17 and 1800s, and I'm sure before that, the #1 cause of death from a complete spinal cord injury was renal failure. Because if your bladder pressure goes above 40 centimeters of water, it's going to back up to your kidneys and you're going to die. And catheter will save your life. A simple little tube will save your life. So they're life-saving devices. The hospital can't function without them. You can't utilize zero catheters in a hospital, but can you get to zero CAUTIs? I think you can. So we've been trying and utilizing a lot of different techniques that have been successful for other people and other places over the years, and we haven't seen a significant reduction. So in order to get people to view catheters differently, I decided I think we need to think outside the box. So that made me look a little closer at why we have them and where the predominant problem is and what we can do to fix it, and try to get some data to support my theory. There's not a lot of data out there, but my suspicion, I think, was correct that catheters aren't evil. We just have to learn to live with them. So I have a good analogy, and I know Wes thinks I'm going to talk about airplanes, but I'm not. I'm going to talk about sharks because everybody knows, unless you live under a rock, that this week is Shark Week. Exactly. Right. So everybody thinks sharks are bad. Sharks will eat you and they'll kill you, right? But the world needs sharks. Why? I'm not exactly sure, but my son can tell you. He's 12. So the world needs catheters, right? In 1992, there was a fellow who said, yeah, sharks aren't all bad, and great white sharks aren't all bad, and they're not out to kill you. He said, I'm going to prove it. I'm going to jump in the water and swim with a great white shark. No one had done that outside of a cage before 92. His name was Ron Askew. And National Geographic said, sure, we'll come and film it, and we'll watch you get eaten by a shark. So he's well-trained, he's well-educated, and he got in the water and he swam with a great white shark. And it was great. He grabbed him on the dorsal fin and he rode around. It was great. He said, see, these guys aren't out here to kill us. They're not bad, right? But he knew what he was doing. So can you swim with a shark? Sure. Can the hospital function with catheters? Sure, if you know what you're doing. Do sharks kill people? Yep. Do catheters kill people? Yep. But you got to know what you're doing. So you have to know what you're looking for. And what we started looking at is why are we having so many in certain areas. It turns out, I'm not going to blame it on the ICU. I'm not trying to point fingers, but in the ICU, we had a lot of them. And it turns out that if you dig deep into many of the catheter-associated UTIs that we found in the ICU, the actual reason for which the patient had the problem was blamed on the catheter-associated urinary tract infection was actually able to be identified on a different organ system. But someone sent a urine culture from the catheter, and they had bacteria in it. And we know that all catheters have bacteria. And a lot of times, they never treated the UTI. They never treated the CAUTI. They treated the pneumonia that the patient had. They treated the sacral decubitus ulcer that the patient had. And the patient got better. And the bacteria that was in the urine, which had a different resistance strain, was never treated. Changed the catheter, the patient got better. So the CAUTI that was supposed to kill them was insignificant. So maybe we didn't need to look for it. And some people view that as looking the other way and turning your head. I say it's, finding the sharks that are going to kill you and leaving the good ones alone. So we started searching for some data. It turns out other people had this idea too. Fortunately, Wes is going to love this because it's his alma mater. But it was the Mayo Clinic, which is #1 in the world for quality. So they had the same idea, and they actually did a study. They studied their ICU patients. They found the same thing. And they found that urine cultures, for the most part, unless people met certain criteria, were not useful in ICU patients. They could not lead you to the source of the problem. So they came up with criteria that they thought would actually help you find it if it was a urinary source of the problem. And they published their data. And their catheter-associated UTI rate went from way above the national average to way below the national average. And instead of calling it turning the other way, they call it a culture stewardship program. They say, let's not treat the ones that don't need to get treated. Let's not find the ones that don't need to get found. Let's find the ones that are significant. Let's find the bad sharks, right? So we're going to expand on that. And I've been in touch with the doctors who initiated that program, who, by the way, received an award from JCO 2 years ago for their groundbreaking work. And we're going to do that plus. So what's plus? We've also got some other initiatives on the floor that we're going to try and improve. One of them is catheter awareness. It's amazing how many people, doctors included, I'll blame ourselves, have no idea how long a catheter has been somewhere. They don't know when it was put in. They don't know who put it in. They don't know why it was put in. And so it just stays there. No one's trying to figure out if the patient's going to be able to avoid it. A lot of times we get consults and people want us to get the catheter out. Getting a catheter out is not always the answer because we don't have any magic pixie dust to sprinkle on people to make their bladders work. And if their bladder backs up, they're going to die renal failure. So we have to work with them. And we have to be able to find out when it's bad and when it's not. So that's our game plan. We've got some protocols that we're developing. Should I start over with the sharks? You guys got that part? So we have some protocols that we're developing. They're not in place yet, so I don't have a success story to tell you. I I hope soon I will have a success story to tell you. So does Wes, and so does everyone else, and so do our patients. So that's where we're at now.
Thank you. And Dr. Kyron? I think. Just want to say that as a urologist here supporting this cause, you're incredible for the work you're doing to help support.
Is that your analysis?
Shark Week. It is. It's a good specimen too. Mary Lynn said it. All right, on that note, we're going to go to our next panelist, and we're going to let Cindy introduce herself and share what zero she is chasing.
I'm Cindy Clace. I am a med-surg clinical nurse specialist focusing on pain. I'm here to talk about the work of the Pain Collaborative, which I am the chair of this group. And what we're chasing is to have zero non-procedural opioid oversedation events. Just to explain a little bit about that, a lot of people are familiar with Narcan because you hear about it related to our opioid crisis. What we're talking about are the opioids that are given to patients while they're here in the hospital. And to not say that opioids are bad. We do need opioids. They are a way to help our patients manage pain. However, there are side effects to the use of these medications, like there are to many medications, and most especially respiratory depression and oversedation. So naloxone, or Narcan, is administered to patients who are oversedated in an effort to improve their breathing. And by tracking naloxone administration and reviewing the circumstances that preceded the event is a great way to help to identify trends and the issues. So I looked at about 8 months worth of data from last year to get an idea about exactly what our naloxone events looked like and to get an idea of where we might be able to make some progress. What I found was that a lot of these patients didn't meet what we would normally think about as patients that would be at risk. A lot of times we think about a tool called Stop Bang, which has looking at patients that have snoring, maybe difficulty with apnea, primarily male. What I found was that over 50% of these patients were medical, not surgical, and that a lot of the patients did not have what would be considered the typical comorbidity of hypertension, but they did have pulmonary issues and they had renal issues. So it gave an idea about the fact that maybe we needed to sort of screen our patients and look at them a little bit differently. So the Pain Collaborative itself was established in October of 2016. And the purpose of our group was to standardize pain management practices, educate nurses and providers, and best practices related to pain management, and to provide oversight for pain management and safe opioid practices. Because our team is so large, it is a system-wide interprofessional team that meets monthly. We have developed smaller, more focused groups in order to address the issues that we've identified. I want to highlight the work of two of these groups. We have an oversedation group that has evolved to include anesthesia. There's just a huge number of people involved with this group, and we're working to standardize how we identify those patients that are at risk for these oversedation events and to develop monitoring practices. The initiative is called ROARS, which stands for the Raleigh Opioid Adverse Risk Screen. And we have a lion as our mascot. And this has developed an electronic version of the Stop Bang screen. We are starting with that, and then monitoring panel. And we've started with our total joint patients for Wake Orthopedics, and we'll expand that pilot as we move along. But it's been very interesting to just see the progress to date with that. The other group I really want to highlight is our non-pharmacologic modalities group. This is a very dedicated, passionate group of clinicians, and we envision having non-medication options as the standard of care for WakeMed patients. Research has demonstrated the benefits of having modalities such as music and massage, healing touch, aromatherapy, and Reiki. And our group has recently been the wonderful beneficiaries of a Hilton Foundation grant that we are using to train WakeMed staff on healing touch and aromatherapy. We believe that using these non-medication options will help tremendously with decreasing oversedation events. I have personally been able to use this with patients, and the response from the patients has just been absolutely amazing. Some of the results to date, and what a lot of this is thinking about just some best practices. In fiscal year 16, the WakeMed system had 117 non-procedural oversedation events that required naloxone and responded appropriately to those. Many times naloxone is given and patients do not have a response to it. So these were the ones that actually had a response. In fiscal year 17, we had 69 events. But that's a 41% decrease. But if that is your family member that has received naloxone, that's not okay. Part of what we attribute the decrease to has been increased monitoring by our nursing staff, as well as the incorporation of multimodal pain management into order sets. Multimodal pain management, for those of you who have not heard me preach my gospel about this, it is the use of our various medications and techniques to actually improve comfort and minimize our side effects. I've also been tracking the use of multimodal therapies across the system and comparing the data from 2017 to 2018. We have had an 18% increase in non-opioid medications across the system. So we are making headway.
Wow. Well, Cindy, you have sure awakened us all to some great information. And if there's any reason to pilot the massage therapy process, I think we need to know where to sign up for that. That'll help out.
Are you volunteer?
It's all for the patients and families, Cindy.
Okay.
To be the recipient. Okay, so now we're going to turn it over to Sheldrick so he can share a little bit about who he is and what zero he is chasing.
So I'm Sheldrick Street. I'm the Director of Surgical Services here at the Raleigh campus, and I am chasing the zero of hand hygiene. And many of you who have nursing units obviously understand that how important it is for us to have never events and always participate in the hand washing, hand hygiene process. So one of the things that I would say about chasing this zero is practicing hand hygiene is simple yet effective way to prevent infections. As the healthcare providers, we all know that hand hygiene is important in every location in the healthcare organization. The CDC states on their website, on average, healthcare providers clean their hands less than half the time they should. On any given day, about 1 in 25 hospital patients has at least one healthcare associated infection. In our OR, it is incredibly important and critical that everyone participates in the hand hygiene process. We all know that we're supposed to wash our hands. Our mothers always told us to wash our hands and wash our hands again. And when we came from outside playing, wash our hands. And even when we didn't want to wash, we were always told to wash. And it was important then, and it's still important today. And particularly in our healthcare environment, our healthcare setting, it remains important. Before you go eating, wash your hands before and after having direct contact with patients. It's important to do so, whether you're taking pulse, whether you're doing blood pressure, performing physical examinations, lifting a patient in the bed. Always wash your hands with every patient contact. After contact with blood and body fluids and mucous membranes and intact skin, washing your hands for wound dressing changes. After contact with inanimate objects, medical equipment, in the immediate vicinity of patients, it's always important to continue to wash your hands. If your hands were moving from a contaminated body site to a clean body site, after your gloves are removed, and after you use the restroom, and particularly if you're about to enter into a food preparation situation. And the reason I went down that list is because some of these basic principles of hand hygiene were very important for us to highlight when we started chasing our zero in the operating room. So where were we? About a year ago, we were at 50% of our folks who were audited were actually doing hand hygiene in the operating room, which goes along with what the CDC says in terms of being 50% of the healthcare providers are actually cleaning their hands. In February, fast forward to February of this year, we were at 93.5%. Huge improvement. In March, we maintained and we were 92%. April, we went up to 94%. In May and June of this year, we had a slight decrease and we're at 89%. So what was the change that made the biggest difference?
And I have to say that that change was when I had a conversation with my dear colleague, Jody Donahue, in surgery, because you can't do these initiatives by yourself. And me being the director, I'm not going to be the person who's always out barking the orders and making everyone listen. So it was very important to engage the right people at the right time. In that situation, it was engaging Jody and having conversation with her as the manager of surgery to say, here's an issue, here's a problem, we've got to figure out what's going on. And we had struggled with this for a long period of time. And one of the things that really became the focus was how was the process being done? So many of you guys remember Vicki Brown when she was here, and I called up Vicki one day and I said, Vicki, I said, you got to help me understand what is this hand hygiene stuff? The numbers are always coming out. We always suffer. I need to know more about this. And she says, well, that's your secret shoppers who's putting that information. I said, well, who are the secret shoppers? And she says, I can't tell you. Like, well, okay, now they can report a number, but you can't tell me who they are. And as a result of that, she says, well, here's the person who you need to go talk to. And I went and talked to that person in our department, and I said, okay, who are your secret shoppers? And they told me who they were, and I said, tell me about the process in which we go through. And they said, well, we do 20 audits a month. I said, okay, well, why are you doing 20 audits a month? Well, that's what's required. And I said, so the 50% is 10 people who didn't do this, but it's being recorded. And we have over 150 people in the department at any given time. That doesn't make any sense, and that was in over a 30-day period of time. So essentially what we did was I called Vicki back up and I said, Vicki, what you're telling me we're doing is garbage, and we got to talk about this in the board. So I met with our team and I said, we've got to redefine what we're doing. 20 audits is not enough for us to understand where the problem is. And if for the folks in the room who don't know, when we were auditing this, I received a report back and the manager received a report back saying by discipline, there was a tick mark on a sheet of paper. So all you saw was a tick mark on the piece of paper saying that a particular discipline did not comply with the hand hygiene. So that was even more problematic because I wanted to know who the heck these people were. Who's not washing their hands? So part of that became we put a new group of folks together and we said, okay, you're going to go out and you're going to secret shop, but you're going to secret shop and tell me who you found and discovered wasn't doing it. It wasn't about excommunicating people from the religion. It wasn't about executing people. It was simply about knowing what the problem was and getting to the core of what the issue was. Because once we understood what was going on, then we had a better opportunity to fix and solve the problem. So what we did from that was, after we understood who the people were, after we understood what was going on, we actually got our audit process up to, and I shudder to tell you this, but in the month of May, we did 559 hand hygiene audits in a single month versus 20. And the month before was over 475 observations of hand hygiene. It helped us understand and define the problem. It helped us to know where our issues truly were. Was it surgeons? Was it anesthesiologists? Was it CRNAs? Was it our nurses? Was it our surgical techs? Was it the ancillary personnel who come into the department? So it helped us to understand who it was, but it also helped us then when we saw the names on the paper, and if there were names that were showing up repeatedly, having conversations. Not threats, conversations. Do you understand what hand hygiene is? Many of our surgeons, and Dr. Keller might be able to solidify this, but maybe not, were saying, what does hand hygiene mean? We had physicians in the operating room who were doing procedures on patients, and they didn't gel before they put the gloves on, nor did they gel before they took the gloves off. And I'm not talking about surgical interventions. What I'm referring to are if they put in an art line, if we started a IV line on a patient. Again, the opportunity existed for someone to do something without cleaning their hands before they touch the patient. That is what we changed. Once we started educating, we started informing, and we provided immediate feedback, we were able to change the process. And that is what our success story is. And one of the things that I tell my team, if you permit it, you promote it. So it's oftentimes about us taking a leadership role, being the superhero, and getting out and doing the right thing for our patients.
Yes. Thank you, Sheldrick, for always being so hands-on with the work you do in your department. Last but not least, I want to turn it over to Catherine, who can share who she is and her story of what she's chasing.
Hi, my name's Catherine Verberg. I am one of the supervisors on 3 West at WakeMed COO, Med-Surg. I'm under Christine Powers, and I've been in my role since 2005.
Extra thank you for being here today. It's been a little busy for her
Yes,
this week.
it's been a bit busy. So the zero that 3 West is chasing is preventing patient falls, which you know very well that a patient fall can have catastrophic events on a patient or anybody falling, for sure. So the WakeMed system decided to challenge us to reduce the number of falls in any unit by 20%. And so we took on the challenge. So in fiscal year 17, we had 36 falls. And I'm not differentiating between injury or not injury. So to decrease that in fiscal year 18, we had to decrease to 29 or less. That was our goal. And so we looked at our data. We looked at between October and February, our October fiscal year starting this past 2017 to February this year, we looked at and we had 15 falls. And you know what? That's over 5 months. It was scary. You know, we were on a trend. We were going to meet that 36 again, and it was not good. It was not good. That was about 1 fall per week, and so that was a problem. We knew we had to do something. So one of our supervisors, Jamie, she went to a falls meeting. She heard about audit tool that was being used on another unit, and she said, "Can I see that?" And so she went and talked to them, got that audit tool, and we decided as a group that, you know what, we could maybe use this, but we needed to change it. It needed to be 3 West. It needed to work. We're a 42-bed unit. I mean, we have 14,000 square feet of space to monitor patient rooms. So we had to make that work. We changed the process. We changed all about the process and how it was going to be used. And then we went out and tested it. We went out and talked to patients, went in using it, and we said, "Hey, we're here. My name's Jamie. My name's Catherine." We said, "We're here to perform a safety check on you." Now, we looked at that. We also had to decide who we were going to start checking. And so we had to decide what kind of patients that we were going to look at. And of course, automatically, we have a complex assessment that we do. We do a Morse scale, and that scale tells us when the patient is a high risk for fall. And so we looked at it. The number is greater than or equal to 45. That makes the patient an automatic high risk. It gets a yellow banner on the EPIC chart. We also thought, well, you know what? We're a surgical unit. So we do a lot of post-ops, and so a lot of anesthesia patients. Patients would have anesthesia. We give a lot of medications, so that was also. And we also looked at, asking our nurses going, is that patient going to fall? That gut feeling that a nurse gets sometimes about a patient. And so patient like who would be impulsive, who no matter didn't score, but just wouldn't listen, just, hey, I got to go better. So we used the checklist, and we put all of those people who were greater than 45 and any of those other ones that we thought might be risk for falls on it. And we started to test it and went into patient rooms and started being able to patient educate and tell patients and families, hey, you know what, we're here to make sure you're safe. These are the things that we do here. And these are all the things that are already part of our policy. Things like yellow wristband, label on the door says fall risk, yellow socks, bed alarms, tabs alarms. Those are chair alarms. So we wanted to make sure of those. Also, our new beds. They're nice. They're great. When the the bed alarm is on and everything is in its proper place, has a green light on the floor. So those are all things that we have available to us. So so we went out, and so the next part we needed to start implementing it. So it was a success when we tested it. So we wanted to go now to implement a process, and we went to the charge nurses. We said, guys, days and nights, we'd like you to use this audit tool to go into patient rooms and to perform a safety check. And so we had a sheet which we used, and had the charge nurses do it, put their the numbers, the forceful risk patient rooms on that list. So we went in to ask them to go morning and night. So that was, so we did it one-on-one education with each charge nurse and did a demo. We took them out there and did it with them. And so we started asking them to do that. And so that was good. And it started working. It started, we bypassed that one fall a week and then no fall a week, Q week, and then no fall a 3 week. But we also noticed, though, that not all charge nurses were on board. So we needed buy-in. We needed them to buy in. So we started auditing, our charge nurses auditing the fall risk sheet, the audit sheet. So then we sat down with each of those where we saw people not bought in and explained to them. And by that time, what was really cool is they saw that we had already had no falls 1 week, no falls the next week, no falls the following week, and saw a trend already. And we could say, there's no falls. So that was great. And so they got on board. So that was what really was good. Day shift was hard too. It was very busy. I mean, it's a very busy unit. And so it was difficult to find the time. Night shift said, you know what, guys, that list is too big. So we cut to check on at night when sleeping patients and things like that. So we made some adjustments about what night shift would check. Just those things that would absolutely prevent a fall had to be checked. So we did that. So to talk about results, things like that, great stuff. So I told you in those previous 5 months, we had 15 falls. Between March and June, that's 4 months, we had 1. So that was extremely exciting to us. We want to talk about the one, though. Of course, you know that you were all over it. So it was a transfer. It was a transfer. The patient had been a fall risk, but things had not been implemented prior, like those yellow socks and those fall wristbands. The patient had been in our patient room 5 minutes, and the nurse hadn't even had time to assess the patient. And you know what? The patient had to go to the bathroom, and it was an assisted fall. So it just was a fall. So we learned from that. Guess what we learned? We learned that we re-educated about transfers and said every transfer is a fall risk, no matter what, until assessed and notified. And then, you know what? We also decided fall risk. Once they're fall risk till they get to the car. So at discharge, at transfer, and while they're with us. So we needed to, in between, we needed to encourage. The one thing I didn't talk about is what do we do when we saw that things weren't implemented? What did we do when things weren't implemented? We would go back. We needed to decide, does the charge nurse just take care of that? Put the fall risk bracelet on and make sure the door is done and make sure the bed alarm is on? Or do we go and engage staff? And so that's what we did. When we saw trends with staff, when we were going room to room and saw trends with staff, we would definitely go to that staff member and educate and re-educate with them, ask them to implement, and then make sure it got done later on. Okay. And so we saw some things where, tabs alarms were unhooked from the tabs up above on the wall where it would hook in. to the chair pad down below. So things like that, now that is never done. So those were good. The next things we also, so we addressed it with staff, and then we would encourage the pizza party every 30 days. We have a little pizza party, sorry board, sorry. And when we would move that little piece all the way around and we get to the pizza in the corner, pizza party, days and nights. So this was good. Recognition, staff meetings. Something else that we saw, patient involvement. When we would walk into patient rooms now, there you go. I got my arm bracelet on. Yellow socks. We're good. We're good. Thank you for keeping us safe. That's what they would say to us. Of course, there's always other challenges, a few other challenges. You know, patients aren't always compliant. Sometimes they refuse. So thankfully, even those ones, they didn't fall. So we're grateful about that too.
And Catherine, what's your final data? You've got some
Oh,
great.
yeah, our final.
Got to give the final data.
Well, our final data is the last 4 months we were 1. So we started this in February. We started this in March, and so we've had 1 fall till June. That's March through June.
That's amazing. Great job. All right, can't leave it out. Catherine, I'm really falling for such an innovative plan. I have to tell you. All right, we've got time for 1 or 2 quick questions, and that's it. So I know y'all have been brewing back there. What questions? Did y'all feel like you got a lot out of this? You heard about their Chasing Zero stories, but what I think is great to hear is those things that we talked about earlier. There were some difficult conversations that were had that led to success. We had those conversations and put in the place of how we're supporting our patient and our care. There was a lot of discussion about collaborative work. It's not about a director or a manager taking this on. It's about everybody being accountable to doing this together. So hopefully those key words you heard are part of the process. So why don't we go ahead, if that's okay, we'll move on. So let's give our panelists a big round of applause.
So our panelists are going to be the first to receive our Chasing Zero pins. We will, and I was remiss in my enthusiasm to mention multiple things that PR is doing. Well, thank you, sorry. I'm going to hand these out to our panelists. They are our first Zero heroes of this campaign, and I hope all of you will identify people on your staff that will be Zero heroes. Some other parts that I did not mention. We'll be asking for all individuals, all people that work at WakeMed to sign the Zero Hero Pledge, that we will pledge that we will continue to chase this for the good of our patients. We hope to have a Zero Hero wall, a pledge wall to put up to show our commitment to going through this. And help me with the rest of it. I'm sorry, I got a lot of it. There's a manager toolkit. You may see a phone Zero walking around somewhere. That's going to be Dr. Hart. No, I'm kidding. So it'll be all on the flyer that you receive. So this is not the end. This is the beginning of a campaign to really push this hard. Because we can do it. We can truly do this. And I would love to come back in a year and that 99 be as close to 0. I was impressed with 1. That's incredible. As close to 0 as we can get it. And even if we don't hit 0, if we have it, pretty good. Love to hit 0 though. So I think we're going to have our contestants come up, and we have a little entertainment for you. Thank you.
Go ahead. All right, so this is the fun, a little bit more fun. We got a treat for you. How many have ever seen a lip sync battle? How many of y'all know who Jimmy Fallon is? Okay, if you hadn't seen it, you need to Google Jimmy Fallon and Ellen DeGeneres in a lip sync battle. It will make you laugh out loud. So if you haven't seen that, you're getting ready to see something just about as funny. And this is what our executive team has in store for you today. So the idea behind a lip sync battle is you lip sync with dramatic and real entertaining perspectives. And you try to win the lip sync hero. So first up, we've got several of our male executives. They're led by Dr. Chuck Harr. And they're here as the WakeMed swooning heroes performing Hero by Enrique Iglesias. Okay, and I had said Cindy's panel discussion awakened me. Whew, okay, there we go. So now that was something else, but our ladies are up next. They're not holding back, they're holding out for a hero. Okay, ladies, Maria, we have our own hero to bring out. Where's their hero? Okay, I will say that Carolyn Knopp was my partner's run, but she is escorting the surveyor to Apex this afternoon, so she canceled on us. So just imagine Carolyn is here as well. Here in spirit. All right, we need Denise and Dr. Har. Where's her? I'm sorry, I missed you in your cake. Bob Falls. Representing the men, we did it Bob Falls. Come on. Falls for the men.
Remember who approves at WakeShare?
You're awesome.
And Pete, you sold us out.
Yep. Okay, guys, we appreciate you being here. Be our zero heroes. Please do your best to chase those zero infections, zero preventable harms. This is going to be an awesome campaign, lots of fun stuff, and we'll see you next month. Good luck to Carrie.
Thank you. Thank you very much. The surveyors were watching.